Good evening, everybody. A warm welcome for everybody to join us for this next session. Tonight's session, I'm going to be the moderator for the challenging cases for the acute kidney syndrome and the complications. We have with me here in the panel Dr. Fawaz Al-Mutiri and Dr. Sundus Samarghandi, and she will join us shortly. We have our speakers, Dr. Abdulrahman Alqahtani and Dr. Haytham Amin and Dr. Muntasir Ismail. A warm welcome for everybody. We will start with our cases, inshallah. Our first case will be presented by Dr. Abdulrahman Al-Qahtani. It's about high-risk PCI on last remaining artery without MCS. Dr. Abdulrahman Al-Qahtani is an assistant professor of medicine. He newly joined from Northern Ontario School of Medicine. Libertarian University Structural Interventional Cardiologist. At present, he's at King Salman Heart Center, King Fahad Medical City. I would love to welcome him to our meeting and to start with the first case, inshallah.
Good afternoon, everyone. I'm Abdulrahman Alqahtani. I'm an interventional structural cardiologist from King Salman Heart Center in King Fahad Medical City, Riyadh, Saudi Arabia. It is my pleasure today to be part of this conference. I'm presenting a difficult case entitled High-Risk PCI to Last Remaining Artery. This patient is a 69-year-old gentleman with a background history of dyslipidemia, hypertension, and type 2 diabetes. He was complaining of exertional chest pain and dyspnea for more than 1 year. His symptoms was getting worse mainly 2 months prior to his presentation to my office. When he presented, he was found to be in class 3 heart failure and resting angina. An echocardiogram that was done in a hospital outside our region, it showed global hypokinesis with ejection fraction of 35 to 40% and moderate mitral regurgitation. I'm going to show his diagnostic range diagram, which was done in a hospital outside our region. The right coronary artery was chronically occluded in the mid-segment with significant disease in the mid all the way to the proximal. And also another view showing the degree of the disease in the right coronary artery. This is the left system that I'm going to show right now. So as you can appreciate, there is significant stenosis in the left circumflex. Also, there is a significant disease affecting the LAD with multiple small branches emerging with giving collateral to the right coronary artery. You might not appreciate the left main to be significantly diseased in this view, but this view will show that the left main is significantly diseased and the LAD is filling late. This is another view. It shows that the LAD is filling but a bit late, and there is a chronic total occlusion in the mid segment. This is a spider view that is coming up right now, and the spider view shows a significant disease in the LCX proximal and the mid, or involvement with OM3 as well. So this patient was seen by a couple of surgeons. He was declined from 2 surgeons for CABG, and a 3rd surgeon offered him very high risk CABG. Patient refused and wanted to be referred for consideration of high risk PCI, as he does not want to undergo a CABG if the risk is too high. And my question to the panel moderator and to our colleagues attending is, what would be your approach, and would you offer this patient anything? So if you offered him PCI, would you consider intra-aortic balloon support or mechanical circulatory support? Which artery you plan to tackle, and role of physiology or imaging if possible. So I would like to take 1 minute to hear from you guys. What's your opinion and thoughts, and then we'll continue on with our presentation. So continuing on with the presentation, so I did offer this patient high-risk PCI. Patient consented to that, and we proceeded by tackling the left system only. The moment we engaged the left main, the patient condition deteriorated, his blood pressure dropped precipitantly, and there was significant damping. So I've sent a PMW wire down the LCX and pulled my guide. As you can see here, most of the injection is outside, and then we had to handle the left main right away to stabilize the patient and get him in a stable condition through the case. So the left main was stented with a 3.5 by 12 onyx drug-eluting stent, and after that we post-dilated it with a 4.0 at that time. And then the patient condition became more stable, and then we decided to go after the LAD. So the LAD has a chronic total occlusion in the mid-proximal segment. We tried to open through true channels using microcatheter. Here it's a fine cross and a pilot 150. We tried multiple times, and we still find that difficult to cross, and we were going subintimal. I continued with the pilot 150 for a couple of times. As you can appreciate here, we still subintimal. And then I changed to a Fielder XT, and I remained subintimal. And then eventually I managed to cross into a true lumen with the Fielder XT. Then I injected through the microcatheter just to confirm that we are through the true channels and we are in the true LAD. And as you can appreciate in these pictures, you can see that the microcatheter is truly into the LAD. We then started with the predilation. So we predilated the whole LAD. And then we took pictures after that to see what the LAD looks like, and you could appreciate there's a dissection in the mid-segment. And then we took another picture of the proximal LAD to appreciate it and to appreciate the disease there. You can also see the degree of the disease in the left circumflex artery. We then, after that, proceeded by stenting the distal and the proximal LAD, sorry, the distal and the mid LAD. And then we used the stent balloon to measure the length of the remaining part of the LAD to be covered. The stent that was deployed in the LAD was 2.75 by 38 onyx drug-eluting stent. We then moved on to predilate the OM3 and the left circumflex artery. Then we stented the distal, the OM3 into the LCX with a 2.5 by 38 onyx drug-eluting stent. And then we use 2.75 by 38 from the mid LCX to the ostium of the LCX into the left main. We tried to stay away from going too much into the left main. We just basically nailed it at the ostium and with a little bit of protrusion. And then we deployed our final stent from the mid LAD to the left main. This is a Zymes 3.0 by 48 drug-eluting stent. And after deploying it, we then post-dilated the LAD into the left main. We took a picture first. As you can see the picture showing now what the LED left main and the LCX looks like. After this, we did do kissing, but I don't have a picture of it here. But then we finished after that by post-dilating the LED. The LED was post-dilated with the 3.0, 3.5, 3.75, 4.0, and the proximal was post-dilated with the 4.0, and the left main was dilated with the 4.5. This is the final picture. So you can appreciate the left main, the LED, the LCX. And you could appreciate the collateral now is more apparent, epicardial collateral and septal collateral to the RCA. And those are the final pictures of this case. So I saw this patient 6 months after his PCI, and then I saw him also 1 year, which was 6 weeks ago. And patient was free of angina symptoms and heart failure, now going for 1 year. We repeated an echocardiogram recently, and this is his echocardiogram. You could appreciate that the LV is contracting very well and thickening very well. You can see here at the level of the mitral valve and at the mid segment that there is a good contractility and there is no regional motion abnormality. This is a 4-chamber view. You could see a trace MR that's coming up now. And his echo now has, the LV has improved with an ejection fraction more than 55% and no regional motion abnormality. His mitral regurgitation has reduced to trace to mild, and he remain free of symptoms, and therefore we should not considering to do any PCI to the RCA CTO. Finally, I want to wrap up this case saying that a chip in a lost remaining artery can be done in patient without the need for mechanical circulatory support. This needs to be planned very well and carefully. And in order to support those patients, you should not be scared to use levofed and phenylephrine, but you should use them judiciously. Those patients require to have a higher blood pressure, especially if you interact with their left main in order to support them. It's also better to be very quick when you're handling the left main, especially if you encounter significant damping and deterioration of patient condition, then the left main should need to be dealt with as soon as possible. In this case, because it was a long case and we were trying to get out as soon as possible without causing any further damage to the patient, we did not do imaging because we deployed the stent in the left main initially, and it kind of derailed us from the main plan. But I would normally consider imaging IFUS in those patients without any hesitation. That's all, and thank you so much.
Thank you, Dr. Abdulrahman, for this great case. It's actually very interesting, the approach without the mechanical circulatory support. I don't have any question yet from the audience, but my question is, in case you faced like a trouble during the procedure itself, would you consider using the Ampella or balloon pump in such case? Was this in your mind, or just you went ahead and you started the case keeping it in the back that I might need it? I mean, did you get the chance to keep it on the table just in case you might need it during the procedure?
So thank you. Actually, in this patient and any other patient that I consider high risk, I normally establish an alternative access. In this case, is a right femoral artery as a backup. I tend to shy away from using mechanical circulatory support unless I need it, and there is an indication clearly push me to have something during the case. And the reason for that, as we know from emerging evidence over the last 2 years, that the mechanical circulatory support in a form of Ampella may actually increase mortality. I think the statement also is not applicable in certain cases where there is definitely a need for mechanical circulatory support. I think it's just the routine use that became more widespread and practice that led to harm more than benefit. In this patient, if I needed to get support, I would be considering that. We do have it in our center, but I try to shy away. I've done a lot of high-risk cases without the need for that. I think what is important in those cases is, number one, you need to maintain their blood pressure high. So I tend to use phenylephrine more frequently than usual. That's one. The other things, when I'm interacting with left main, I try to minimize that interaction as much as possible. So fast inflation, don't delay stenting, try to hit and run as fast as you can. And this is, I think, in this case, I was forced to handle the left main at the beginning because the patient was not tolerating even just being engaging the guide in that. So I need to stabilize them. And after we handle the left main quickly, patient stabilized through the case. But we do have the support ready if we need it. And through the number of cases I've done, fortunately enough, I did not have to use any mechanical circulatory support for such patients.
Perfect, perfect. Fawaz, I will go back to the question that Dr. Abdulrahman posed in the earlier of the case and measuring the syntax score for such patient and like reconsidering. I mean, he was turned out by two surgeons, if I do remember, and then the third one was telling him that it's going to be high risk procedure and on all these things. To tell you the truth, we don't want to like say we want to jump and like do the procedure as much as have a decent discussion, maybe the heart team to be involved in such cases. What do you think, Fawaz, about it?
Yeah, first of all, thank you very much, Abdulrahman, for sharing your case. It's a very difficult one. And I think in these cases, I believe PCI will carry a higher risk than surgery. Coverage will be the best approach. I know the reality, sometimes you face a problem with your heart team that if the surgeon declined the case for any reason, you get stuck and you have to deal with it in the cath lab. But if there is any way to push it for surgery, I still think that PCI would be way higher risk than taking him for coverage. Second, if you end up deciding for PCI, this kind of cases, I think it's the planning. Again, we cannot argue success. You did a great job, a great result at the end. But it's again, retrospect here, I will definitely consider circulatory support. Again, aortic balloon pump doesn't work in this case, but Ambilla do. And if I need Ambilla, that means you need a lot of preparation. So I will not be in a situation that I have to put an Ambilla in a rush. Putting Ambilla will make things under control than emergency. Again, you end up by putting a quick stent in the left main to save the patient. Maybe if you have circulatory support, that will help you in doing more the strategy that you start with. Second, again, if you end up with a lot of metal in the coronaries, especially if you're dealing with the left main, I will definitely use an imaging, either IPS or OCT to optimize it, because the risk here for him in the future for instant restenosis and stent thrombosis will be very high. So optimization of my result will be great. Again, to summarize it, I will definitely push for surgery. But what you did is a great job. You saved him from the crash that he went to. And definitely the final result is amazing. You have all the branches out of the LED, and LED distally is great. And the size of the stent that you selected, I think it's appropriate. So good job.
Thank you,
good job. Dr. Abdulrahman, we have a comment here, maybe from Dr. Samih Lawand. His comment was regarding he said the last patent vessel was the left circumflex artery. Would you have considered doing first, as it is simple and would be supportive toward doing the LAD, particularly because the LAD could be much more challenging? It is the choice which one to start, I would say, the circ or the LAD in such case. I think you started with the LAD and then you went to the circ and then you finalize it with the LED. So the question is regarding if you go retrogradely, would you have like done the circ first and then go to the LED, or you would go for the LED and then start with the circ?
Sure. So just want to comment first on Dr. Fawaz's feedback. Definitely, I would agree with Dr. Fawaz that surgery would be the best option in this patient with very high syntax score. He's unfortunately was turned down, and he is high risk. Those kind of patients do crash when they've been inducted. And that's the problem that the surgeon are afraid of handling those patients because they do crash during induction. The guy with the class 4 angina, he was having resting angina and he was very symptomatic. And looking into the left main and the LCX, it is reasonable that we could help him at least with those artery. Why would I choose to go after LAD in this case first before fixing the LCX and offering some circulatory support? Because the LAD in the situation is a CTO, and I wanted to attempt the CTO first because if you manage to open it, it is a big bonus. But if you didn't manage to open it, then you can still go back and finish the LCX to the left main in this situation. So I normally tend to attempt the CTO arteries if the other arteries still need to be handled. In certain situations, you might need further protection, like in case you need further handling, further support to the heart, you would try to work on another artery. But in this case, if something went wrong with the LCX itself, and you don't have a left main, you don't have an LAD, you don't have an RCA, then it's a game over situation. So I try actually in this situation to provide more circulatory support to the patient by opening his CTO first. I hope that answered the question. Okay. One last comment in terms of imaging. I do totally agree with Dr. Fawaz that imaging is paramount and crucial in this situation, and we would normally do it in every single case. We just had a technical difficulty. The patient, I did angio later on this patient and reviewed it with IVUS, and things were excellent at the situation, but okay. I did include it because there was a follow-up.